Good afternoon. Thank you for joining us for the Ask a Radiologist webinar series. Before we get started, I'm going to share some housekeeping items for today's webinar. Everyone on the call will remain muted for the duration of the webinar. At the end of the webinar, we will open the floor for live Q&A. We encourage you to ask questions, and you can submit your questions at any time using the chat box feature in the Zoom platform. For today's webinar, we are joined by Dr. Leah Carlson. We also have your physician liaison, Travis Roseborough, on the phone. If you have any needs regarding patient education, referral forms, or other materials, Travis could stop by for a visit at your practice. Dr. Leah Carlson is a radiologist subspecialized in breast imaging. She attended Colby College in Waterville, Maine for her undergraduate studies and Wayne State University School of Medicine in Detroit for medical school. Dr. Carlson completed her radiology residency at Emory University in Atlanta, Georgia, and her breast imaging fellowship at University of Michigan in Ann Arbor. In her spare time, Dr. Carlson enjoys traveling, hiking, paddleboarding, any water sports, including scuba diving, reading, and spending time with her husband and 2 sons. I'll now pass it over to Dr. Carlson to begin the presentation.
Thanks so much, Alexa. So wanted to talk a little bit today as we sort of hit the 2-year mark of this COVID pandemic about some of the non-infectious disease related fallout from the last 2 years, and in particular focusing on the slow return of women to screening mammography, in addition to the implications of us detecting later stages of breast cancer sort of post-COVID shutdowns. So in all, trying to help us get back in the habit of encouraging our patients into preventive care. So the goals today are to review some basic breast cancer statistics, to discuss some changes to screening exams and elective care that occurred sort of over the last 2 years during the COVID pandemic, and review some recent literature that's actually starting to put numbers to what we're seeing anecdotally in our breast centers. So just a kind of a basic reminder, breast cancer remains the second most common cancer in American women, with skin cancer being first. Approximately 1 in 8 women, or 12.9%, will be diagnosed with breast cancer throughout their lifetime. And 5-year survival rates vary significantly by stage at diagnosis. This sort of probably goes without much saying, but we're at a point in time where with localized breast-only disease or microinvasive disease or micrometastatic disease, we can achieve nearly a 99% 5-year survival rate in our patients. And that's why, just to underscore sort of the importance of early stage detection in breast cancer mortality and morbidity statistics, that significantly decreases with just regional metastases up to the lymph nodes, and regional lymph nodes down to about 86% at 5 years, and with distant metastases, not surprisingly, quite a steep drop off at 29%. So as we all know, in March of 2020, our lives drastically changed with the onset of sort of the COVID pandemic hitting American shores. We saw ourselves all struggling with limited personal protective equipment and limited understanding of what we were dealing with. And so there was understandably a significant diversion of resources to the acute care setting. And as we all probably remember, outpatient and elective procedures and exams were largely suspended. In the breast world, many breast centers across the country just sort of stopped routine screening mammography initially in March, staying open to manage symptomatic patients or to complete workups that had begun pre-shutdown. And then furthermore, many elective surgeries, which included many early stage breast cancer surgeries at many centers, were also delayed, with patients often being managed with chemoprophylaxis instead of going straight to surgery as they would have in a pre-pandemic scenario. So, you know, what's the non-infectious disease implication of all of this? So sort of just before the pandemic, or sort of extending slightly into the early months of the pandemic, there's a British medical journal study that had been looking at the impact of delaying treatment on mortality. And you know, this we then can apply sort of post-pandemic, but what was found sort of mirrors what we expected, right? That delays of 8 to 12 weeks in achieving treatment, in most cases surgery, or initiation of chemotherapy for our neoadjuvant patients, that delay of greater than 8 to 12 weeks was associated with a 17% higher risk of cancer-related death, and a delay of greater than 12 weeks, I think greater than or equal to 12 to 16 weeks, was about a 26% increased risk of cancer-related death. And obviously, the longer the delay, those numbers just continue to increase. So similar statistics in this study were looked at with in terms of other cancers. Most similar to breast were head and neck cancers. And then what they didn't, and they openly acknowledge that they didn't even look at, but we can probably extrapolate some negative effect to as well, is additional morbidity that's undoubtedly associated with the diagnosis and treatment of later stage cancers, larger surgeries, more aggressive chemotherapy regimens, more aggressive lymph node dissections, things like that, that we know also will increase with delays. And so this is, the delay and the risk of cancer death was unrelated to stage, but we know that delays also lead to later stage disease in most instances. And so kind of coupling those two things. And then looking a little bit more at what is the actual COVID impact and what happened during both the shutdown, that, March to May for most facilities, March to June, and what has happened since. And so there was a study out of Kaiser Permanente where they looked at their cancer statistics from March to May of 2019, and then from March to May of 2020. And what they noticed, not surprisingly, is that the diagnoses of symptomatic breast cancer increased. As you can imagine, if we're not screening, we're going to find fewer screen detected cancers and more symptomatic breast cancers, but the numbers are fairly significant. So it went from 37% of their diagnoses in that time period in 2019 to 78% of their diagnoses in 2020. Additionally, they were noting more aggressive subtypes diagnosed in the 2020 era. And so stage T1C or higher was up to 78% of their cancers in 2020, up from 64% in 2019. And triple negative cancers similarly saw a significant increase, up to 16% in 2020 and 10% in 2019. Similar findings were identified in a UC San Diego study that continues to be ongoing, but looked instead at how many stage 1 cancers did we diagnose in 2019 versus 2020, and then in 2021 to sort of evaluate, okay, so we had that shutdown period. We expect that there's going to be fallout from that. What's been the longer term fallout? Did women immediately return to screening or not? And what was sort of the implication one way or the other? And so again, sort of disturbing data that they found that 64% of their cancer diagnoses in 2019 were stage 1 cancers. Again, those are the cancers that achieve that near 99% 5-year survival rate. Those are the ones that if we have to find them, we want to find. That dropped to 51% of cancer diagnoses in 2020. And as of June of 2021, that had dropped further to 42%, telling us that either women are developing more aggressive cancers for some reason, be it immunologic, environmental stress, something like that. And we're seeing women who perhaps missed their screening and so are presenting later, either for screening or with symptomatic disease in 2021 now, that maybe missed 2020 completely. And so we're seeing them present with later stage disease at a fairly significant rate. NYU, again, saw something very similar. They instead looked at rates of breast biopsy recommendation and then subsequent cancer diagnosis and how that changed from January 2019 to September of 2020. And so they broke it down sort of as a pre-pandemic period, which was January of 2019 to March of 2020. And then a pandemic period, which was March of 2020 to September of 2020. So they saw that during the pandemic period, again, not surprisingly, we screen fewer women. We're going to have fewer biopsy recommendations. by about 24% in their patient population. But beyond that, there were also 38% fewer screen detected cancers in the pandemic period relative to the pre-pandemic. And so what's different in this study than the Kaiser study is that they actually extended their sort of post-pandemic period longer, beyond just when our breast centers reopened, and they still found that there were significantly fewer screen detected cancers in that pandemic period prior, relative to the pre-pandemic period. Additionally, they detected fewer symptomatic cancers in the pandemic period, which again also probably suggests women were maybe not getting into their primary care offices, their OB/GYN offices, to have clinical breast exams at their regular intervals. And so unless they self-detected, there was going to be a certain number, a catchment of those patients who just didn't get any medical care and a clinical breast exam, to decrease again the number of symptomatic cancers that were diagnosed. What was interesting in this study, and probably a little too much to really bite into, but I want to at least bring it up, was that they also identified significant racial disparity. And we know that there are significant racial disparities in the world of breast cancer to begin with. The access to screening imaging there are disparities. We know this pre-pandemic, we know this post-pandemic. Access to care past screening is also, there are significant disparities for a variety of reasons. And then we also know that breast cancer has different behavior that can be somewhat race-based and race-linked, and that there are certain racial groups that are either more prone to triple-negative cancers, like Black African-American women tend to be at slightly higher risk of more aggressive cancers, even if all other access is controlled for. So what was disappointing in the NYU study is that they did see that there was the largest decline in cancer diagnosis occurring in Asian and Hispanic women, then Black women, and then non-Hispanic white women. And so again, it just shows that not only are we seeing these negative fallout from changes to how we take care of our patients in this post-pandemic period, but it's further exacerbating racial divides that we know already exist. And so they sort of discussed that a little bit more in depth. Again, widened racial disparities in both access to breast cancer screening and diagnosis of early stage breast cancer in underserved populations, and that some of the primary barriers to care are things like decreased access to care. A lot of folks lost their insurance or became underinsured during this period. Differential access to specialists and technology. As much of the healthcare world moved onto an online platform, even for regular well checks and primary care visits. Obviously, if you don't have a computer, you can't see your specialist or your primary care provider, and certainly not with as much ease. Similarly, geographical access, ability to get to the doctor if you live further away became more difficult for folks as we were social distancing and spreading, and as there were changes to things like public transportation and access to various medical specific transportation options. That could vary. And again, this study was out of NYU, so there's likely linked a lot to either fears of using public transportation or true limitations of those services. There was note made that language barriers or lack of understanding of what was going on contributed significantly, and that those things again were exacerbated to a certain degree by the use of technology and how we took care of our patients. And again, education as always, allowing access to specialized care, understanding of needs for genetic testing, both on the side of the patients and the side of ourselves and our primary care community and our OB/GYN community, understanding that some of these various racial groups have and need specialized care. Those things, those disparities that already existed were just further exacerbated. So I just wanted to at least touch on that, because I think that probably has some impact on our patient populations here in Charlotte as well. I wanted to, again, before we kind of talk about what can we do about it, just note anecdotally that without officially pulling numbers or providing, producing a study. I know that that we're seeing this play out in our clinics every single day here in Charlotte. And I actually have only been here in Charlotte for about the past 6.5 months. And prior to that, I was working in a group up in Northern Michigan. And so that's where I was when the pandemic began. And I was running a breast center, a breast program with my group up there. And what I can tell you is that we did pull the numbers from our sort of March to end of May when we were reopening our breast centers. And what we found, and then pre-pandemic, and what we found was that on average, we were diagnosing about 5 to 6 cancers a week pre-pandemic. And that dropped in the March to May period to an average of 1 to 2 cancers per week. So even just on a small unofficial basis, we absolutely saw that that we were not capturing the patients we should be capturing and diagnosing the patients that we should be diagnosing. And again, likely for all of these reasons. And it would be very interesting to look at it here in Charlotte. And I think at some point we probably will, to see how it's impacted our patients here as well. Because again, I know I am seeing more late stage disease, more metastatic disease, node positive disease than I recall seeing in the last 10 years of practice. So what can we all do? We need to continue to create safe spaces in our healthcare offices so that our patients feel comfortable coming back for care. And we need to communicate with them to alleviate fears related to, I think for many patients, the fear of catching COVID at the doctor's office is maybe not such a big issue anymore at this point. But I think there's also other concerns as our patients kind of come back to trying to get back in the habit of getting their primary care appointments taken care of and coming in for their screening mammograms and other screening tests, colonoscopies, et cetera, et cetera. We need to continue to work as a system to improve our patient movement through the various stages of care to decrease systems-based delays in achieving end treatment. If that British Medical Journal, even outside of COVID, tells us anything, it's that we can always do better, and we need to do better, because these even week delays, month delays on our patients have potentially really significant long-term impact on their overall outcome. And then, kind of bringing it back to just screening mammography and other screening preventative care tests, the pap smears, the colonoscopies, the lung cancer screening CTs, things like that, is that we have to look at our patients groups, see who we haven't seen, and make sure that they're getting those ordered. I know here at Charlotte Radiology, I think we're looking at about 20,000 women who we are trying still to contact and get back in for a screening exam. Whether or not they've had one somewhere else, don't know if all 20,000 of them just haven't had care in the last 2 years, but they've at least fallen out of our system. And so we're trying really hard to get them back. And obviously I'd encourage all of my primary care and OBGYN colleagues to try to the best of our abilities, do the same, get our patients back into our offices, making sure that we're doing also, when we see them, breast physical exams, and ordering diagnostic mammography appropriately so that we don't delay access to sort of next level care. Sometimes we'll see gals come in self-referred for a screening, or they show up with a palpable. And so just making sure that we order it correctly from the get-go will also further delay any, decrease any delays. And so with that, kind of a lot really quickly, but I'm happy to take any questions, and thanks for being here. And certainly my contact, if you have additional questions or concerns, always happy to interact.
Thank you so much, Dr. Carlson, for that informative and extremely important message that you shared with us. To everyone that's on the line, if you have any questions and you would like to ask them now, you can enter them into the chat box feature and we'll go ahead and read them aloud. Or if you would like to ask your question live on the call, if you click on the raise hand button, I'll go ahead and be able to unmute you. So we'll give it a minute for people to gather up their questions.
Dr. Carlson, this is Travis Roseborough on Physician Liaison. I want to thank you for giving that excellent overview. I have a couple of physicians here, and they just said that they were very thankful for the information that you've provided. I just wanted to say, with your information, I think there's going to be some changes. What major changes for healthcare facilities do you think we should implement?
Oh, that's a good question and a big question. Do you mean in terms of getting folks through the door, or in terms of getting them quicker or more targeted access to care? I guess it's kind of a big question otherwise.
I think that the providers here are thinking about the in the door.
Yeah, it's a great question. I can tell you what we're doing here at Charlotte Radiology is we have folks on our back end kind of combing through our data and our patient jackets essentially to see who hasn't been here in the last 1 to 2 years, and how, can we contact them? Can we call them? Can we text them? Can we send them a letter saying, hey, don't forget about this really important part of your health and of your self-care, quite frankly. We've all been living through a really stressful couple of years. I don't think there's not a one of us who it hasn't had significant impact. So I think starting by reaching out, I know certainly we've done some work with marketing, certainly not so much from the perspective of financial marketing, but just in terms of patient education and getting patients in the door, and sort of trying to remain a presence. And so, to the best of all of obviously everyone's busy and every practice is busy and overtaxed. I can only imagine what it feels like to be in the primary care world right now. But to the best of our abilities, just trying to reach out to folks we haven't seen in a while and see where they are, and if they're still here with us, if they just need a push really to get back in the door.
Thank you so much. I think the physicians here, we were talking, and they were saying is that they have tons of patients that they've lost contact with, and maybe the information is gone, so they don't know when to give up because they send the information out, and sometimes it's just kind of pointless. To one of the providers' messages, he said that he's been calling and contacting, and sometimes even the number is disconnected. So. They're working very hard.
Yeah, no, I have no doubt. I think we all are. I think, for me, looking into this a little bit and seeing it playing out in actual literature was just that much more eye-opening. It was all things that I was seeing. I'm sure everybody in the community is seeing as well, that the patients that do show back up, because they're showing up with, and it doesn't just relate to cancer. I would imagine we're seeing other disease processes that have sort of become more aggressive or evolved more rapidly in this period. My honest answer is I don't have all the solutions. I'm not sure of the best way of how we capture patients other than sort of presenting, a united front as healthcare workers. I think there's been a lot of mistrust and fear that's been sown also over the last several years, and I'm sure that's not helping either. So just trying and continuing to try to the best of our ability. And continuing to try to educate and put real educational material out into the world and on social media versus, some of this that's fear mongering and pushes patients the other direction.
Thank you, Doc.
Thank you.
All right, so we'll give it just another minute or so to see if any other questions happen to come through. And if not, we can give you guys back a few minutes into your afternoon. Okay, so I think that's all for today then, Dr. Carlson. Thank you again so much for taking the time to give this extremely informative discussion. I know we've talked about how the delay in breast screening can lead to more breast cancer diagnoses later on for all patients. And now this is just an extremely important message to get out and spread out to everyone that can be affected. So thank you again for sharing this. And to everyone on the line, if you have any other further questions or comments or something that you just wanted to share with Dr. Carlson, just one off the webinar, here is her contact information. Please feel free to email her and she'll be happy to connect with you and speak with you at a separate time. So again, thank you so much for everyone for participating in today's webinar. And I hope you all have a great afternoon.
Thank you.